through North America. And another bright light decided, well, the mongoose would maybe be a good thing to introduce into Hawaii because it would eat the rats and do that sort of thing. But what they failed to understand was that the rats were nocturnal and the mongoose was active during the day, so they're not out at the same time. So the islands that have, I don't know whether they're mongeese or mongooses, anyway, have the mongoose, what has been happening is that the beautiful songbirds have been disappearing because the mongoose eat the eggs. So, we don't know how things are going to be affected. And I remember a year or so ago, somebody did this experiment and dumped a whole bunch of iron shavings way out in the middle of the Pacific Ocean, and to try to help feed the algae so it would feed the fish. Everybody went ballistic about this person putting rust into the ocean. And it was terrible, it was going to cause all this damage. The stuff we're talking about here in terms of our metaphysical environment, our philosophical environment that we're living in, is way worse than a little rust in the ocean. Also, palliative care physicians, who are the physicians who are closest to the people of caring for the people who are in these situations, are overwhelmingly opposed to this practice. Our organization did a poll, and you can see that are you for or against legalizing euthanasia? 88% were against it. 90% were unwilling to participate. Assisted suicide, 80% against, 83 unwilling to participate. Because we understand how vulnerable people are at that stage in their life, and how open to suggestion they are, and how they're already feeling as though they're a stress on their family, and that a way out like that would be undue pressure for them. So these folks are all disability rights activists, and they've written some really interesting stuff. You can look them up once you get the PowerPoint if you want. Marilyn Golden she wrote a really interesting article called Killing Us Softly, The Dangers of Legalizing Assisted Suicide, and she has some real interesting things in there. She's talking about the prejudice against disability, and this person says, Janet Good says, pain is not the main reason we want to die, it's the indignity, okay? It's the inability to get out of bed or get onto the toilet. I can't stand my mother or my husband wiping my butt. And then it says, but as many thousands of people with disabilities rely on personal assistance have learned, needing help is not undignified, and death is not better than reliance on assistance. Have we gotten to the point that we abet suicides because people need help using the toilet? I mean, what does that say about us as a society if we are doing that? Diane Coleman, I know her, she is one of the co-founders of a disability rights group based on the Monty Python thing, I'm Not Dead Yet, they call it Not Dead Yet in the United States, and she said at a conference where we both spoke, it's extremely offensive to me that others would say they would rather die than live a life like mine simply because I leak. She's a lawyer, she's argued cases in lots of different courts in New York. And so Marilyn Golden says, the reason that patients choose assisted death, for example, in Oregon, loss of autonomy, 90%, loss of the ability to engage in activities that make life enjoyable, loss of dignity, loss of control of bodily functions. They had pain down there. The people who were the original Hemlock Society, and their name has morphed to Compassion and Choices, but they were the ones that drafted the legislation there and drafted the categories, and they had the category of pain, and they didn't even have 2 or 3% who were saying that pain was the reason. So they added pain or fear of pain, and they still only got, with fear of pain added, 18%. So it's more about these other issues. And so the percentage of Oregon cases talking about patients' reluctance to be a burden to their families was 12% in '98 when it started, and by 2007 it was up to 45% of the people that was one of the reasons that they gave. So here are some of the problems that are happening there. The reporting requirements completely lack teeth, and noncompliance isn't monitored. This is the Oregon Public Health Department says in its first year, we cannot detect or collect data on issues of noncompliance with any accuracy. So when they tell you there's no problems there, this is the Oregon government saying that they can't detect noncompliance with any accuracy. So who are you going to believe? The people say, oh, everything's fine, or the government that says we can't even tell you? Important questions are unanswered. There's no investigation of abuse. It says that the Department of Health there has no authority to investigate individual death with dignity cases. So if it looks fishy, they don't have any authority to investigate it. Secrecy pervades in Washington State, for example, if this is such a great idea, why not put it on the death certificate? It's illegal for the doctor to write that the person made use of the Death with Dignity Act, is what they call it. You have to say that the person lied. On the death certificate, you have to say the person died of the underlying disease. So if this is such a good, why is it not on the death certificate? And there is another, and the data are destroyed every year. I don't know how long you have to keep your records here in Ontario, but in BC we have to keep them for 16 or 17 years after the patient reaches the age of majority. The raw data are destroyed in Washington and Oregon after 1 year. So Dr. Golden's conclusion is, talking about all these things, given the absence of any real choice, death by assisted suicide becomes not an act of personal autonomy, but an act of desperation. It is fictional freedom. It is phony autonomy. And as other people have said, the choice between living without supports and dying is not a real choice. My friend Amy Hasbrook is the Canadian head of Not Dead Yet. She has and she has written this, she's wrote a really interesting little article about how about my right to cry for help, so that if you're a person with a disability, if 90% of suicide attempts are a cry for help, then why is it that you want to make sure I actually get it done the first time? What about my right to cry for help? And so she's visually disabled, but she had her sister-in-law draw this cartoon, and it shows this brick building with steps up to the front door that says suicide prevention, and a wheelchair ramp up the side that says assisted suicide. So Carol Gill has written 2 excellent articles about disability, and one of them is called "No, We Don't Think Our Doctors Are Out to Get Us," responding to the straw man distortions of disability rights arguments. And she's a person who has post-polio syndrome and needs a respirator, and she's had people come into her hospital room when she's had to be hospitalized for certain things and change her respirator settings without even talking to her. And if she had not had a voice to be able to speak, she would be dead. This is my little friend Ross Harding, who died in 1996 at the age of 10. He had Menkes disease, which was it's impaired copper transport, and he needed to have, he had serious connective tissue problems, you can see with his hair and his teeth and everything, but he was just zany and wonderful, lived in Saskatoon, and he was around when the Latimer case was on. And he said to his mother, who's a physician, he said, Mom, if I get sick again, you don't have to kill me. I can take it. So this is a 10-year-old who is worried about this issue. And then he was really upset that they couldn't get an IV started on him one day, and he said to his mom, God didn't make me right. And his mother is a very wise person and just kind of shrugged. And then the next day she came back and he said to her, Mom, I figured it out. None of us gets made quite right until we get to heaven. I just got made wrong differently than most people did. And it's kind of interesting. If you say that disability is a reason, which one of us is perfect? Ross understood that at 10. So what are some of the problems where it's already legal? So Dr. Herbert Hendon is the head of he's a full professor of psychiatry in New York City, and he's been the head of the International Suicide Prevention Organization, and Kathleen Foley is a full professor of neurology at Memorial Sloan Kettering, and they did a detailed study of cases in Oregon in the first 10 years, and this was published in 2008 in the Michigan Law Review, and it looks long, it's a long thing, but it reads like a novel. It's very interesting what they found. And they found that the evidence strongly suggested that the safeguards are circumvented in ways that are harmful to patients. In fact, one of the Oregon Health Department things said that we trust the doctors to be their usual careful selves. Well, it's kind of interesting that the tax people don't trust the doctors to be their usual careful selves. They follow up. And another thing, the final conclusion was that Oregon physicians appear to have been given great power without being in a position to exercise it responsibly. And actually, even the Oregon and Washington laws are written in such a way that depression does not disqualify you. If you are competent, even if you're depressed, you're supposed to be allowed to make use of the law. And they talk about all this coercion, they only have to be 15 days and all of these things, but the final sentence is, patients are left unprotected while believing they have acquired a new right. And a physician, the sad thing about it is in Washington and Oregon, a physician actually is more liable if he or she treats a patient and doesn't do it very well than if he kills the patient illegally or wrongfully or doesn't do that well. Because the only test for whether the physician should be prosecuted or whatever is whether the doctor acted in good faith. That's it. That's the protection. And one of the elder law specialists there, Margaret Dorr, talks about how an heir can help to sign the person up, can be one of the people, and you do not have to have a witness, a dispassionate witness at the time. So basically what's happening from the time that the lethal dose leaves the pharmacy, it's just saying that your death is not going to be investigated. So this idea that, well, people just like to have that lethal dose just in case they might want to use it is very dangerous, because someone, if you struggled, who would know? And the other little thing that's really interesting about that is that that if the person dies of natural causes or from something else, the lethal dose is not recalled by the pharmacy and it just floats around out there in the community. Now we talk about that. The self-administering, someone else putting the dose into the patient's mouth qualifies as self-administering. So and people who can stand to benefit from your estate are allowed to be involved in this. And we know that elder abuse is really increasing. So this is not something to be, everybody thinks, oh, my family is great, but that we're not talking about just for ourselves, but what about our culture? We've had a couple of call-in programs in Vancouver, and the stuff that happens to older people that they call in and talk about is amazing. One woman has 2 wills, one for the daughter that the daughter who lives with her knows about, who has been very abusive to her, but another one that supersedes that one where she gets nothing after this woman dies because she's afraid to even do anything with that because the daughter will kill her. So by signing the form, the client's taking the official position that if he dies suddenly, no question should be asked. Okay, Linda Ganzini, who's a psychiatrist there in Oregon, said that 20% of the people were depressed who did this. So how voluntary really is this if you're depressed? Depression is a treatable illness. And Harvey Chachinoff from Winnipeg did a study and showed that the prevalence of depressive symptoms was 59% among patients with serious and pervasive desire to die, but only 8% among patients without such a desire. So are we just washing our hands of people with depression? And the other thing is that they really found, Dr. Ganzini's done a lot of work on this, and she found that the main reason that people wanted this was because of fierce independence. And that when they asked the families afterward about the symptoms that people were having, no patient in the people that they interviewed had a symptom that was rated at a greater level than 2 out of a possible 5. So it wasn't about pain or breathlessness or nausea. It was this fierce independence of wanting to somehow control death because it was controlling them. I'm almost coming to the break, so I know you can smell the coffee. A study in the Canadian Medical Association Journal in 2010 This one is really important. It shows in the Flanders area of Belgium that 32% of the people who, and these were the people that the doctors reported that they had hastened death. So they only do that in some place between 60 and 70, some places only 45% of the time. So when they followed the rules and they've said they've hastened death, 32% of them, so 1 in 3 of these patients, the doctors said that they had no explicit consent from the patient, okay? And they gave all sorts of reasons for it. The patients also tended to be, and they didn't call it killing the patient, they called it life-ending act without explicit request, so LAWER, okay? And they tended to have non-cancer diagnoses, such as dementia, other things like that, and they also tended to be diagnoses that didn't have as easily discernible timeline. So you didn't know how long people had. And they tended to be less mentally competent. And my favorite one is that at about 9% of the time, the reason that the doctor said that he or she did not ask the patient about whether or not, and just went ahead and euthanized the patient, was that it would be too stressful to the patient. Okay? So people who think that this is about choice need to think about what the Belgian doctors are saying, that my evaluation of your life is more important than what your decision is. Alex Schadenberg has a really good analysis in this little booklet he put together, and only about half of the deliberately hastened deaths were reported in these Belgian studies, and the ones that were reported followed the guidelines, and the other ones tended not to. They had things like nurses giving the doses, all these other things. It's a really good read, that one. It's not very big. And then also, it has expanded. Since 2005, the Groningen Protocol has been in place in parts of Belgium and in the Netherlands, and this is talking about the euthanasia of newborns. And right now in Belgium, 9% in Belgium and 7% in the Netherlands of the children who die under 1 year of age die by lethal injection. And in Belgium, only 81% of the physicians involve the family in any aspect of this decision. And a lot of these children have things like spina bifida and can live fairly normal lives. So 19% of the time, so 1 in 5 of these children was euthanized without the parents ever being asked if they wanted to take this child home and care for this child and love this child. So anybody who thinks this is about personal choice needs to think about some of these issues. This is not a church person. This is a reputable scientific journal these are reputable scientific journals that are publishing these things. This is the Dutch government's own website, that minors can request euthanasia from the age of 12. They have to have the consent of the parent or guardian until they're 16. 16 and 17-year-olds don't need parental consent, but their parents have to be involved in the decision, and by the time you're 18, you don't even have to involve your parents at all in the decision for euthanasia. And this is really interesting when we understand that scientifically, the brain is not formed fully until the person is about 25 years old, and the connections with the frontal lobe are not properly worked out yet. And so what that means is that you do not have the understanding of how what you're doing today is going to affect things in the future. And that's one of the reasons why car companies, they figured this out a long time ago. The car rental companies, they don't rent to people under 25 because they know that they're not thinking about the future. They just want to go out and run the car. So, but this is what it is. And Belgium has just now passed a law for euthanasia for children. We also had some other really glaring examples. There are deaf twins who were going blind within the next 5 years, and they decided that they're 45 years old, they'd lived together, they were shoemakers, and if they couldn't see each other's faces, they didn't want to live. So one of the doctors bragged about this in the media and said they had a cup of coffee with their parents and their other brother, and he took them in a room and put them out of their suffering. This is not terminal. This is what is being argued right now by one of the lawyers in the Carter case. We think the federal government has no place at the bedside of seriously and incurably ill Canadians who have made a firm decision about the amount of care they wish to receive at the end of life. So we talked about already having the right to refuse care. Does she really mean that the government should not be involved in regulating health care at all? I mean, do you really want to live in a country where the government doesn't say, you know, this needs to happen? Especially since only 30% of Canadians, the parliamentary committee, the 3 out of the 4 parties were involved. The Parliamentary Committee on Palliative and Compassionate Care found that only 30% of Canadians had access to adequate palliative care. That means 70% of us do not have access to adequate palliative care. So anyway, she says, and so my questions are like, who decides they're going to end of life without the dignity they deserve? So who decides what's dignified? And does it necessarily follow that being denied a hastened death means that it's not dignified? And if people don't think that this is meant to expand, they should have a look at what Jocelyn Downey wrote. She is one of the lawyers who's been an architect of getting this before the courts. And she said, there are many individuals whose lives are no longer worth living to them who have not been diagnosed with a terminal illness. They may be suffering greatly and permanently, but are not imminently dying. There is no principled basis for excluding them from assisted suicide. So if you think that you can have safeguards, you're coming up against this. If you think safeguards can work, then you're going to have to deal with this about who is going to define that my suffering as someone who's had, I'll make something up, has had bipolar illness for 25 years is not worse than someone who is going to die in 6 months from lung cancer and who knows that the person is going to die. Why is my suffering being discounted? It's going to be a human rights issue before the courts. Dr. Donald Lowe, we all saw his plea on television, and they said that he died at home in his wife's arms and did not have any pain. And yet somehow, because he had not been able to hasten his death, that was considered undignified. I'm here to say that dying at home in your wife's arms with no pain doesn't sound like an undignified death to me. Now, I'm not trying to discount how he felt about it, but what are we saying as a society if that is our idea that somehow you have to die 2 weeks earlier? I have not been able to find the quotation, but he apparently had some sedation at the end of his life, and if you find it, I would be very happy to have it. But his wife made some kind of a comment such as, why should I have had to live with a corpse in my house for the last 2 weeks? He wasn't a corpse. He was still a living human being, and I think that's where we have to get our heads around it. We also make mistakes. Jeanette Hall is a person from Oregon whose physician, whose oncologist, was really uncomfortable with her making this decision right away, and he kind of put her off a number of times. She finally decided, okay, she'd go for the treatment, and she's still alive 14 years later and is very happy that he stalled her because she would have been dead. And we have to look at the discrepancies that are already present. You look at what it looks like on a geriatric ward versus a pediatric ward. I don't know whether you've been in a nursing home or a geriatric ward, but they always choose colors of paint that suck the light out. There's no reason. I think you should lose your license as a care facility if it smells like urine when you walk in the front door. I mean, who wants to live in something like that? But the choice between death and that is not a choice. And just looking at those rehabs, also there's this idea of dogs. There's so much demand for no-kill shelters. And even dogs that have huge behavior problems and have attacked people and everything, well, they deserve their retirement, they deserve this, they deserve that. A guy named John Katz has written a book called The New Work of Dogs, and he was talking about this issue, and I thought it was really interesting. This woman who keeps these dogs, and she's given up so much in her own life. She has 70 or 80 dogs, and she hasn't, it says her personal life is terrible. She hasn't seen her grandchildren, hasn't seen a movie in 5 years. And he said, there's a vast subculture of transporters, screeners, fosters, and people who follow up to make sure the dogs are doing well. While I'm in awe of their heroic work, I'm also conscious of the fact that there is no equivalent national network for troubled humans. If you type dog rescue into Google, you get nearly 750,000 hits. If you type people rescue, you get 5 or 6. Now, what about the older people who have nobody to visit them in the nursing homes? Do they not deserve the same kind of care that these dogs are getting? This is my last slide, you will be happy to know. This is a man named Parker Palmer, who's a thinker and an educator. And one of the statements he made is that violence is what happens when we don't know what else to do with our suffering. He said, I think that axiom applies on every level of life. When individuals don't know what to do with their suffering, they do violence to themselves or others near them. So I'm going to let you just think about that during the break and some of the other things, and then we'll come back afterwards, and you'll be happy to know that the second part is shorter. So.